Welcome to How to Triage Trauma Cases. This is part one of two parts, so hopefully you can join us for part two later on. I'm a Massey University graduate and I started in mixed animal practice in the South Island and then gradually made my way to emergency work before jumping the ditch to work at Melbourne University in their emergency critical care department. And I currently work in Perth at a multi-specialty referral hospital as an emergency and critical care clinician. So what you see as trauma presentations will depend a bit on your location, whether you're city or rural. It will depend on the demographics of your local population and also on people's attitudes to roaming animals. Some examples in this talk will be fairly extreme, and they're to give you an idea of how to handle different cases. Your bread and butter traumas are actually generally very mundane. I'm terrible at remembering to take photos, so if we relied on my collection, we'd get a few relevant photos and then a bunch of really cute Australian animals. So I've dealt with the cases I'm presenting to you today, but the photos have been very generously donated by colleagues around the world. Over the two parts of this talk, I'm hoping to give you an overview and a framework so that you can think about how to approach a trauma no matter what type comes through your door. How you treat individual cases is going to depend on how you like to practice, what your practice policies are, and what resources you have available and what owners will let you do. So you will see trauma patients. It doesn't matter where you are, you will see them. They comprise about 11 to 13% of admissions to tertiary small animal veterinary centres. So in general practice, this number might be lower for you, but you're still going to see them. And they actually make up the second leading cause of death for dogs of all ages. The outcomes can be really good. The prognosis can be excellent. But that depends on a variety of factors, some of which we can influence. So if you're not an emergency centre, you're going to be fitting these traumas around your existing patients. While if you are an emergency centre, you might be dealing with multiple patients at once. So you need to decide who gets seen first. You can also have multiple traumas arrive at once. For example, all the participants in a dog fight might arrive at the same time, or if multiple pets are travelling in a car that's involved in an accident, you might see all those pets at the same time. And you need to decide how to direct your resources, which include your time, your staff's time, and your physical resources to the most appropriate patients. You also don't want animals with life-threatening conditions to be sitting waiting in the car park or in reception. So you want to be able to identify and intervene with those patients early. And you want to stabilise patients rapidly because that can improve your outcomes considerably. So the types of trauma we might see vary hugely and can include vehicle accidents, dog fights, hunting injuries. Machinery can be fairly dramatic. Machinery injuries such as chainsaws and combine harvesters, misadventure, self-trauma, and then wildlife adventures. And in New Zealand, you're unlikely to see things like this, but it does depend where you live. So triage starts with a phone call, and one person's emergency might not be another person's emergency. So, for example, the little kitten on the left presented at 2 a.m. for lumps on bum, which ended up being perfectly normal testicles, whereas the incoming phone call for the puppy on the right was actually a cut to lip. So the perceptions can vary quite widely between owners. It's also important to remember that what we are used to seeing on a daily basis can be really horrifying for owners, and particularly when it's their beloved pet or they have no medical background. As we're talking about trauma, most owners will usually have witnessed something, or there might be blood or a collapsed patient or wounds. But we tend to err on the side of caution when we are interpreting what owners tell us, and we advise most of them to come in and be assessed. All staff in the clinic should be trained on how to phone triage. And it starts with getting a little bit of pertinent history. So you don't want to cause a delay in presentation, and you certainly want to keep owners focused, because some of them will start talking about Fluffy's diarrhea 3 years ago, believe it or not. But it's important to keep calm them, and try and keep them focused. Reassuring them that first aid is available is really important. You don't want to have owners delaying seeking treatment, particularly if they're cost constrained. You just want them to come in as quick as possible. If possible, get them to use another driver, as emotional drivers are not good drivers, and it also frees the owner up to administer first aid to the pet in transit. Be succinct with your advice and really focus on the important things like safety. Even the nicest dog may become aggressive when in pain, so you can advise owners on things like placing simple wrap muzzles, which could look something like this, and safe moving of painful patients, which can be done with household items like blankets being lifted on all corners. Other advice that can be quite useful over the phone is the application of pressure bandages and placing a clean dressing, even if it's just a clean tea towel, over open wounds, exposed bone, things like that. Also really important, if they're planning to wash the pet, to discourage them from doing that. Just get them presented as quickly as possible. Life-saving advice that you can give includes how to administer mouth to nose, how to do chest compressions on the way, and when to place a pressure bandage. Once you get off the phone to the owner, you can start preparing for their arrival. So this is our basic setup when we have a trauma coming in. And you can see here we've got some cleaning equipment, some pre-cut tape for the catheter, clippers that work, and we test them before we lay them out, and then a variety of catheter sizes. We do use T-ports, but we don't place them in large patients during the triage phase. They're added later, because you can't deliver fluids rapidly through a T-port, so we don't bother with them in our large patients. We routinely take a PCV and a gas light from the hub of a catheter as it's placed, and we run those just as a matter of routine. If we have any indication that the patient has any respiratory compromise, we will have a method of delivering oxygen set up. We will have equipment to intubate and equipment to clear secretions ready to go. If you have ultrasound, it's really helpful to have that turned on and ready to go, and have your X-ray machine set up and ready to go as well. Right next to our triage area, we also have an oxygen source. We have suction and various suction tips handy. So immediate treatment is warranted for any of these situations, and these patients should be brought back to the treatment area immediately, with or without the owner, depending on your practice policy. As the patient arrives, they often have quite dramatic injuries, and it's really important not to get distracted by the gory bits. So if something isn't life-threatening, don't worry about it in the initial triage phase, just ignore it. So we've all heard of airway, breathing and circulation, and these are still the foundation of your triage, but you can actually get a lot of information as the patient is brought in before you even touch it. So try to get some baseline information before you give analgesia, as things like mentation can be altered afterwards. As the patient approaches you, you have a quick look. What is its breathing like? What is its effort and rate like? Is it dyspneic? Is its mentation appropriate for the situation? And is it walking? And if it is it lame? If it's not walking, you need to make a note to later find out why and to assess deep pain. You're also looking for any glaringly obvious problems at this point. While you're doing this, you can start getting a little bit of information from the owner as the patient's approaching. So what happened? When did it happen? And what have they done to the patient since? So some owners will administer medications at home that might be relevant. Some will have washed off all the blood, which will make it more difficult for you to find injuries later on and may have caused contamination. Some will have fed them recently, and some will have actually watched them overnight. So an injury that you think is really fresh coming through your door might actually be 12 hours old already. It's really important at this point to find out, was the patient normal prior to this incident? So what you don't want to do is find out that Fluffy actually has been diagnosed with terminal cancer prior to this, but that the owners are just too emotional to tell you. You invest a lot of time and resources into stabilizing him without knowing this information. So the other thing to find out is just get an indication of what owners want to do. If they are already expressing severe cost constraints, that might be quite relevant at this point if you can already see that the patient's going to need a lot of work and resources to stabilize and repair. I always get permission to assess and stabilize patients, just verbal permission at this point, even though that's what they've been brought to you for. It's a good thing to do as they're brought in. All of this can occur before you think about analgesia or touching the patient, because it takes a matter of seconds, not minutes. And analgesia can affect your later assessments of these patients. So your initial triage is quite quick. Is your airway patent? Is there any swelling or developing swelling that's going to affect breathing? Is there any obvious tracheal damage or any blood that may become aspirated or cause occlusions? With breathing, you're looking primarily at rate, effort, and pattern. And if you have any penetrating thoracic wounds or any suspicion of penetrating thoracic wounds, this is where I would use Glad Wrap. We keep a full roll in clinic at all times, and just whip a couple of rounds of Glad Wrap around the whole thorax, which will prevent a pneumothorax from worsening while you're triaging your patient. You also want to check if your thoracic wall movement is symmetrical and adequate. The key take home is that if you are thinking of taking control of an airway, it is already time to do so. So if you're starting to think, should this patient be intubated, go ahead and do it. So IV access and oxygen can happen simultaneously with your quick initial triage. Our nurses are fantastic. They will actually start putting in a catheter and start supplemental oxygen as the patient is wheeled in pretty much. And we also tend to use a lot of fentanyl as our first-line analgesia. It's important at this point, before you fully assess your patient, to avoid drugs like butorphanol, buprenorphine, or NSAIDs, because they may not be appropriate, and you won't know that at this point. So oxygen is not going to do any harm. So if you're in any doubt at all, give oxygen supplementation until you know the extent of the trauma that you're dealing with. It's not an expensive treatment to give, and it can be life-saving at this point. Your options for delivering oxygen include flow-by, mask, nasal catheters, and oxygen box. Now, nasal catheters can be fiddly to place, they can be irritant to the patient, and they're often not appropriate if there is facial trauma or a lot of bleeding. So we tend to use primarily flow-by. Some patients will tolerate a mask, but in general, particularly cats don't seem to appreciate masks, and we're trying not to distress these patients to the best of our ability. So we will predominantly use flow-by, just holding the end of the oxygen line as close as possible to the patient. Oxygen boxes are great ways to deliver oxygen, but they do mean that you can't triage at the same time. So we tend to use them in the set later on once we know what's going on with the patient. So things that we might see following trauma are facial trauma, so trauma to the structures of the face, swelling of the pharyngeal tissues, tracheal tears, and bleeding. And dealing with these in the triage setting might require sedation. So again, opioids can be really nice for this. Oxygen, sometimes you need to support the tissues, like in this little guy, and other times we need to take control of the airway via intubation or a tracheostomy. When we're talking about breathing, the main things we tend to see with trauma patients are contusions, hemothorax and pneumothorax, and you use your effort rate and pattern to assess these things. Other things to have on your radar include non-cardiogenic pulmonary edema, and we tend to see these with the strangulation type injuries. So animals that have been dragged by their collar behind a car if they've fallen off the back of a ute, dog fights where one dog has grabbed the collar of another and become twisted or snagged on it. This is a presentation that will also occur a lot with head traumas, so be aware of that. We see contusions with any form of blunt trauma, and hemothoraxes are pretty common as well. Now, just be aware that you can actually get considerable blood accumulation from hemothorax before it becomes a clinical problem requiring drainage. So if you have just a hemothorax, we tend to actually not drain them very frequently unless they're causing clinical problems. Unfortunately for our patients, hemothorax often presents in conjunction with contusions, and then the tolerance for fluid within the thoracic cavity is much lower, and we tend to have to drain them at a much lower mil per kilo volume within the chest cavity. Pneumothorax is really common, and it's important once you've successfully drained them to just monitor for a repeat buildup, because a lot of these will have ongoing leakage for a little while. So again, penetrating thoracic wounds, glad wrap is your friend in these guys until you can drain the pneumothorax, get them stable and prepped for surgery. So many clinicians, in my experience, are quite reluctant to perform a thoracentesis, and they really shouldn't be. It's a fantastic diagnostic and therapeutic procedure and can be life-saving if you have a pneumothorax. Now, as ultrasounds become more and more common in clinics, I think we're using thoracentesis less because we can use our TFAST to establish if there's free fluid or air in the chest. But it is still absolutely fine to do a diagnostic thoracentesis and have a negative one. That's really useful information in itself. I'd recommend tapping bilaterally because not all patients have a patent communication in the mediastinum. So this is our setup. We again have a working set of clippers. It's an aseptic procedure, so we have cleaning equipment. We're really lucky we have clear drapes, clear plastic drapes, so that's really useful for identifying your landmarks. And then if we're suspecting a pneumothorax, we use a butterfly catheter attached to a three-way stopcock and a syringe. While if we are looking for a hemothorax, we tend to use a larger gauge catheter with a short extension set and a stopcock. And we would use a much larger syringe than this one. That's a bit stingy. So your circulation, it's really important to remember that all these parameters, the heart rate, pulses, and mucous membrane colour, as well as the blood pressure, can be affected by pain and catecholamine release. So you have to actually look at the whole picture when you're assessing the circulation and see, for example, is the animal excruciatingly painful? Has it had massive blood loss? And take them as a whole patient rather than just individual values. In terms of treatment, analgesia, fluids, and fluids are actually one of the most useful tools in our arsenal. Many clinicians are very cautious in trauma patients with fluids and tend to way underdose them. So if you are wondering if your patient is requiring fluids, you can do test boluses. And the way to sort of think about that is if you're worried about pulmonary contusions, you might go on the low end, so maybe a 5 ml per kilo bolus, whereas if the lungs seem fine, you can go higher and go, let's say, 10 ml per kilo. And you give that quite rapidly over about 5 to 10 minutes and then reassess your patient parameters. So how have these changed the pulse rate, the heart rate, the colour? If these have all moved towards normal, then your patient probably did want fluids, and you can either give stop at that point, or if these values get worse again, give another one. And so you can actually bolus to effect in that way. Just remember that the rate of fluid administration matters as well as the volume, because these fluids are going to move into the interstitium. So we give these boluses usually over 5 to 10 minutes. Permissive hypotension is a technique where if you have considerable hemorrhage, for example, you aim to restore blood pressure to a level where it will perfuse organs, but not necessarily to normal. And the aim of that is to prevent any clots that are just starting to form from being knocked off by the increased blood pressure. So minor injuries, when we're talking about analgesia, include things like torn nails, skin lacerations, cat bites, and buprenorphine is usually quite appropriate for those. If you're going to use a non-steroidal, your patient has to be stable. They cannot be systemically affected by the trauma. So we tend not to use them in the initial triage stage, but if it's obviously a torn nail, then a non-steroidal is fine. For most other injuries, we would begin with an opioid, and I really, really like fentanyl. You can administer it during triage because the time it takes to place a catheter and give intravenous fentanyl is still less than the time it's going to take for either methadone or morphine to be absorbed from an intramuscular injection. So the need for a catheter to deliver fentanyl is not a reason not to use it. Fentanyl is also really nice because it can be titrated to effect. It works really well if you then need to anaesthetize a patient to take airway control. It can form part of your induction protocol, and it allows judgment, assessment of response to pain, and then either increase or de-escalation if you find that your patient's not as painful as you thought. Some people I find worry about causing nausea in trauma patients using opioids, and then worry about aspiration if they vomit, or worsening head trauma. And we've found that in general, if a patient is really painful, they're not going to experience nausea if you administer opioids. So we very, very rarely see it, and we quite happily administer opioids to all our patients. Obviously, availability varies by country and practice as to what you stock. So intravenous access, sometimes these veins are not what we wish they were. If you're dealing with hypoperfusion, sometimes going to a really small catheter will allow you to get it into a vein. Obviously, we would still love the biggest catheter possible, but you can always switch them out. You can go small and then change to a bigger catheter once the patient's more stable. Warming the limb will cause vasodilation and can make it easier to catheterize. So sometimes we will put warm water in surgical gloves and pack them around a peripheral vein for a minute or two. And if you need to, you can do a cut down as well. Sometimes you will need to place a catheter in a less than ideal location, for example, near abrasions or bite wounds. And in the triage setting, that's perfectly fine. Just remember to change that catheter to a more suitable location once your patient is stable and other veins become more viable. If you've got trauma to a limb, such as the picture on the right, you can obviously try other limbs. You can try less traditional veins on the same limb, for example, the dorsal pedal or the accessory carpal. And you can also place a temporary catheter in a location you wouldn't really want one long term, and then change it out again. If peripheral veins are just not working for you, then a jugular catheter is always a really nice option for your trauma patients. So head trauma, it is absolutely imperative to maintain perfusion to the brain. So you want to avoid hypotension and hypovolemia. And for that reason, it is always okay to give fluids to these patients. Far better that they have fluids than that they don't. It's also really important to avoid hypoxia, so we deliver oxygen to these guys, and hypercapnia, which sometimes means having to ventilate them if they can't do it for themselves. We like to promote venous drainage, so angling the patient's head at a 15 to 30 degree angle will help promote venous drainage through gravity. It's really important not to occlude the jugulars by putting a towel under their head or neck. So we tend to try and angle the whole patient. Very little patients go on a clipboard, and bigger ones go on any type of rigid flat board that you can put on an incline. Your main choices with osmotic diuretics are the mannitol and hypertonic saline, and they just work through osmotic effects to reduce intracranial pressure. We don't withhold analgesia from head trauma patients, but we do tend to be more cautious with it than with our other patients. Because if the blood-brain barrier is not functioning normally, we can see more depressant effects from our opioids in particular. So we will again often start with fentanyl and start low dose, and then based on how the patient is tolerating that, titrate to effect. It's also really nice and short acting. So if you find your patient becomes severely depressed, even on a low dose, it's not going to be in the system for very long. The modified Glasgow Coma scale is a really nice tool for giving you an objective measure of how these patients are going as you travel along with them. So it's important to remember that shock, musculoskeletal damage, and neurological damage can be hard to differentiate in our trauma patients. For example, a cat in severe shock with pelvic fractures may not give an appropriate pain response to a toe pinch. So it's really important to stabilize these guys first and then reassess their neurological function afterwards. In small patients, it is often possible to palpate pelvic instability, but it can be very hard to tell between a high femoral fracture and a pelvic fracture. And the reality is that you don't need to know the difference initially. It's just important to know that there is a problem in that region. And also important to remember that these type of fractures are often associated with massive blood loss around the fracture site, which won't necessarily be visible externally. Many patients with pelvic fractures can still walk. So an owner saying my dog or cat is still walking doesn't rule out a pelvic or high femoral fracture. And they'll often have a wide-based crouching gait with these type of injuries. Very fat or muscular patients can make it more difficult to palpate fractures, but even in very thin patients, you can't always palpate them, sometimes quite surprisingly. So this cat, even though it has quite an obvious fracture on X-ray, this wasn't palpable at all externally. It's just something to be aware of. It's also really important to talk to owners as soon as possible. So I like to talk to them as soon as I've done my initial assessment. And the approach I take is to start by reassuring them that their pet is being cared for, that they are receiving analgesia and oxygen, that a nurse is with them, and also that we'll reunite them as soon as possible. I find this helps to calm them and actually helps them focus on what I'm trying to tell them. At this point, I often get a little bit more history because it can be quite relevant to what you recommend next. For example, if their pet is totally impossible to medicate at home, then certain treatments are not going to be appropriate for them. Or if Fluffy already has major mobility issues at home, then recommending an amputation is not really appropriate for this pet or family. So it can give you a bit of an idea of where to go with your recommendations. I then usually discuss what I've found so far and what the implications are. And things I really focus on are that we often don't know the full extent of the injuries, and we may not know them for some time. So it's important to explain to owners that stabilization is much more important than diagnostics, and that we don't want to kill their pet to get them the answers of what's actually going on. The injuries can also take quite a bit of time to present. So particularly in the case of dog bites, they might not show the full extent of their injuries for several days, or things like traumatic myocarditis might not show up for a couple of days as well. So I pre-warn owners of these so that if they do occur, they've got some idea that that was a possibility. Costs are a really important part of your discussion, and it's important to be upfront and warn owners that things might change. So the estimate you give now might not be appropriate in 8 or 12 hours. And also that sometimes what might appear to be quite an attractive and cheap option, for example, bandaging a wound rather than repairing it, might not actually be the cheaper option in the long run and could be an equivalent or greater cost because of the length of time it'll take to heal. If it's not going to compromise patient welfare, be prepared with a plan B, C, D, X, Y, Z if finances aren't going to allow option A that you've suggested. And if you think amputation is something that might be indicated, I try and mention it really early in the piece because many owners are absolutely horrified by the idea when they first hear it, and it can take some time to get used to it. So the longer they have to think about it, and especially if you present it with some anecdotes about patients who actually do really well with only 3 legs, the owners can then make a less emotional choice when it actually comes time to make the decision later on. So in summary, triage really does save lives, and it's important to focus on the basics, be prepared, and look at the whole animal. Communication is probably one of the biggest aspects of getting your patient from that initial triage situation through to actual definitive treatment and home. So in part 2, we're going to focus more on diagnostics and when is a trauma not a trauma, and then I'll go on to some case examples and take you through those. Thank you very much.